Dr. Ravi Kamapalli. I'm a board-certified infectious disease, wound care, and obesity medicine doctor. I'm in Augusta, Georgia, and the topic I'm discussing is for this conference on Zoom for a session in India called Madhu Prayas 2020, which is an initial conference. But I'm pre-recording this in preparation for live recording, and I thought I should record this and see how it goes. The topic is therapeutic carbohydrate restriction and nutritional ketosis, an evidence-based carbohydrate restriction approach. And from a disclosure standpoint, nothing much except removing barriers to healing. And also I'm involved in finding process solutions for infectious disease, wound care, and obesity medicine in removing barriers to healing for those problems using people, process, and technology. I'm invested in a telemedicine company also, and I practice as a clinician. And I do follow therapeutic carbohydrate restriction as my lifestyle. The objectives are introduction to therapeutic carbohydrate restriction and nutritional ketosis, and low carb, healthy fat lifestyle, and discuss the evidence on remission for type 2 diabetes mellitus and what international organizations are saying regarding that, and also discuss evidence-based, well-formulated carbohydrate restriction modalities and review the gaps in the knowledge and how to figure out and develop interdisciplinary approach with multidisciplinary involvement of different staff members with n equal to one approach for removing barriers to healing in delivery of nutritional solutions. Just wanted to start with a case. On June 20th, I saw this patient of 2020, a male 65-year-old diabetic with severe obesity and a BMI of 40 and a chronic kidney disease and associated fatty liver, and diabetic on 2 medications for diabetes, and wanting to get rid of diabetic medications and is being frustrated with his overall care. And he has a large abdominal pannus and presented to the nutrition weight loss obesity clinic after he had some toe ulcer and toe evaluations done. So his initial presentation was with a weight of 240 pounds, and in 2.5 months, it came down to 230 pounds. And if you see, this is a body composition analysis that was done, which shows that patient's problems with his fat mass showed significant improvement, and his BMI reduced from 38 to 37, and fat mass went down from 95 to 83 pounds that he has to have lose. And also, basically, his visceral fat mass level has come down from 19 to 16, and his excess fat mass now that he has to lose has come down to 58, and his basically total weight loss was 10 pounds and fat loss was 11 pounds. So there is some fluid fluctuation there. But overall, what we did with him was do a feasting, fasting, and time-restricted eating approach with cognitive behavioral therapy and telemedicine tracking and personalized nutritional solution. That's what I want to stress, how impactful this gentleman's outcome has been. And I'll show the modalities as to underlying thinking behind this improvement for this gentleman. He was able to get off his 2 medications of diabetes. Now he's off insulin and he's off other medications, oral medications too. Now, glycemic continuum and cardiovascular disease has a path through diabetes, and most heart disease patients have a root cause of underlying etiology of problems with diabetes. It's all about insulin resistance and how it develops over years. This was a European Heart Journal in 2013. I took this schematic from, wherein the microvascular combinations of complications of patients develop long before. But we have to understand that the hepatic glucose does not worsen until the diabetes starts, but more so, it is slow rise of insulin level. Once the severity happens, the endogenous insulin production goes down, but the hepatic insulin glucose production goes up, and that hence starts the microvascular complications, including neuropathy and also eye changes. And typically, diagnosis happens, and it takes decades for this to happen. Now, what does a doctor do when you have a toolkits that are available, but we are taught that food as first approach is not an easy approach. So we are taught to give medications, whereas there's other diet tools like, say, a DASH diet, low-fat diet, low-energy diet, Mediterranean diet, paleo diet, and vegetarian vegan diets. But I would want to propose the idea that therapeutic carbohydrate restriction is the most important of them, and there is different variants in it. There's a low carbohydrate, there is ketogenic, there is carnivore, and there is fasting. Benefits of controlling carbohydrates include all these significant improvements, including weight loss and improved health indicators, including triglyceride improvement, inflammatory marker improvement, overall stress improvement, alertness, appetite control, and also improvement in multiple facets of life, which we are going to go through. Macronutrients have an impact on blood sugar. We have to understand that once we eat carbohydrates, the blood sugar spike happens. With carbohydrates, there's a 100% spike, with protein, almost 40%, and fat, I think 4 to 5%. The insulin and insulin-associated complications lead to chronic diseases. These include most common diseases of diabetes, heart disease, cancer, and stroke that account for almost 3 out of 4 deaths, and multiple other complications of insulin resistance, including fatty liver, PCOS, migraines, arthritis, stroke, and multiple other issues, including skeletal problems, urological problems, and circulatory problems. Metabolic syndrome, which we focus in our practice mostly after infectious disease, which is my primary specialty, is trying to understand that metabolic syndrome that leads to all these complications has at the core of it the 3 of the 5 criteria that are needed to diagnose it, but all the 5 criteria have insulin resistance as an underlying etiology, and it appears to be the unifying theory of chronic disease. What is insulin resistance? It's nothing but a subnormal glucose response to endogenous and also exogenous insulin. Obesity can be associated, and it could be nutritionally driven because of insulin resistance. Stress can cause insulin resistance. Medications, including glucocorticoid medications, and also human immunodeficiency virus, antiretroviral medications, pregnancy, insulin, and antibodies that are associated with insulin antibodies might cause this, and genetic defects. So glucotoxicity can happen because glucose is a very rigid planar molecule. When it is in the blood, it damages the epithelial cells and the nerves. And as you might be aware, the glucose coats the sugar and causes something called as glycation products. And end glycation products are advanced glycation products, which is called AGEs, are the root cause of most of health issues that we face, with glucose causing this problem, but we have to understand that fructose causes it 7 times. After a glucose load, you can see an example where red blood cells can get clogged up like this. And it is coming to my notice that glycans that are noted are the real underlying issue behind most problems of life diseases. And I'm trying to learn more about glycans, and that's a whole another discussion. But glycans can regulate lifestyle, and changes in glycans are often visible before the diseases happen. Now, let's go to the nutritional ketosis basics. It's nothing but a metabolic state where body is predominantly fueled by dietary fat or body fat. It occurs when the carbohydrates are limited and proteins are moderate, and ketones are produced in the liver as a part of fatty metabolism. Ketosis also occurs during multi-day fasting, as it has to provide 60% of the brain energy. Nutritional ketosis is not ketoacidosis. High-fat diets in the pre-agriculture time were the norm, and in 1920s it was used for epilepsy at Mayo Clinic. And also, ketogenic diets eliminate most sugars, grains, and also starchy, non-starchy vegetables, and also fruits, most fruits. And ketogenic diets result in sharply reduced insulin levels. And this is noted to show improvement in the insulin prescriptions, and improved energy and mood is noted. And there's a lot of knowledge being accumulated with CGMs being used with reduced glycemic excursions that happen. Importantly, insulin is a signal also for kidney to store the sodium and fluid. In ketogenic diet, there is reduced insulin, so there is a loss of sodium, and keto flu, quote unquote, happens because of electrolyte loss. So electrolyte replacement early till the fat adaptation and understanding is very much necessary. We'll talk about the levels of ketones and ketone readings in the next slide, but we have to understand that in addition to weight loss, there is multiple effective way in which ketogenic diet helps, including people with hypertension improvement, heart failure improvement, metabolic syndrome, cancer, and all those etiologies. So it has been shown that it has endurance athletes that can be using it. Now, this time scale, if you see, nutritional ketosis and ketones were discovered long before, around 1850. And this was used for therapeutic purposes for seizures in 1920s, and even studied in Inuit diet, that is in Alaska. And now, in 1972, there were studies done by George Cahill on fasting and ketosis, and then came Atkins, but unfortunately, then also came the US dietary guidelines, and that changed the whole problems. And now again, slowly but steadily, there has been surge of ketogenic research, and more research has been done in the last 5 to 10 years, and there's more data on it. We're going to discuss on it. Before we go to that, we have to understand that what is ketogenesis and how does that happen. Some basic slides I'll show, wherein we can see that acetyl-CoA is the origin of ketones, and it is manufactured by two acetyl-CoA molecules. It become through HMG-CoA lyase and HMG-CoA synthase, and that becomes acetoacetate, and then from acetoacetate come acetone and beta-hydroxybutyrate. Now, acetones are spontaneously released from acetoacetate, but beta-hydroxybutyrate comes from use of beta-hydroxybutyrate dehydrogenase. And this can be stored in the blood. So essentially, ketones form the fuel and signaling properties, and also has direct signaling properties and metabolite signaling properties. We have to understand that ketones are produced in the liver through this pathway like we discussed, but the mitochondria in the liver can't use ketones. The extrahepatic mitochondria are the ones that use ketones. And this is a pathway that I just wanted to show you. We know about glycolysis, we know about Krebs cycle, but it is the confluence of Krebs cycle, acetyl-CoA, fatty acid metabolism that we have to understand in this whole process, that acetyl-CoA is appearing to be the fulcrum for all these processes. But also we have to understand that in glucose metabolism, the increase of production of citrate leads to increased production of VLDL and triglycerides. That's where the fatty metabolism and increased triglyceride happens with increased carbohydrate intake. Now, this was a slide I was telling us earlier. We have to understand nutritional ketosis is a blood ketone markers, mostly beta-hydroxybutyrate, and that is when you have range of 0.5 to 3 millimoles. That is when you are in a state of nutritional ketosis. So basically 0.5 to 3 millimoles, after which it could be starvation ketosis, or more than 10 millimoles per deciliter, you will go into ketoacidosis. And in people who do produce insulin, it is highly unlikely that you would go into ketoacidosis. Only you have to be insulin insufficient for this to happen. I just wanted to bring to the point that is mostly missed when people don't understand ketogenic diet and kind of blame it. This is what opened my eyes to this whole nutritional lifestyle, wherein when we eat carbohydrates, there is insulin increase. And these two hormones, lipoprotein lipase and hormone sensitive lipase, are some things that we have to understand. The activity of lipoprotein lipase is increased when the insulin increase happens. So lipoprotein lipase activity is increasing the glycerol and fatty acids that are broken down to push the glucose back in through the opening of GLUT4 transporter into the cell. And the problem is the triglycerides form here, but after that, for the triglycerides to come out of the cell, of the fatty cell, we need hormone sensitive lipase. But what happens is when there is increased insulin levels, there is reduction in hormone sensitive lipase activity. So the fatty acids cannot come out of the fat cell. So hence, reduction of insulin in the blood and sensitizing the insulin level in the body is very much necessary. So this is another slide for understanding that the dietary definition of kind of diet for optimizing nutrition is carbohydrates of less than 20 to 50 grams for ketogenic, and other discussions are here for moderate carb and high carb diet, and wherein patients had to be having well-formulated ketogenic diet for nutritional ketosis. And we have to understand that for nutritional ketosis is needed for optimized excellent human potential, because it is an excellent fuel for the brain, heart, and skeletal muscle. It is a potent epigenetic signal. And also, the cons for this are significantly because we cannot implement these changes easily as per the understanding of the science of implementation clinically right now. But there are long-term studies that are being done right now for that. And there is studies that have proven that at least for 2 to 3 years, there is an intensive program that is effectively able to be delivered. The teaching has been flawed to the physicians. People have been taught to be afraid of ketones as the fuel, with DKA being shown as the problem. But we have to understand that in the last few years, there has been increased understanding, and ketones is a superior fuel. It has hormone-like activity. It has activity in synergistic with PI3 kinase inhibition, which is very much what is needed in patients with problems with cancer. People have to understand that it is beta-hydroxybutyrate that is very effectively inhibiting histone deacetylase. And also, it is much more than a metabolite. It has direct effect on insulin resistance. Obviously, it is acting through the mitochondria with also ketogenic diet, improving and blocking the NLRP3 inflammasome. So we have to understand that also beta-hydroxybutyrate suppresses oxidative stress. It inhibits NLRP3 inflammasome and has a significant positive effect on nutrition, metabolism, and aging. And also, it helps with the way in which our protein wraps around the DNA, and the gene expression. So these are multiple studies that have shown that with bariatric surgery, with carbohydrate restriction, there is remission of diabetes that can happen. And metabolic syndrome by itself has been shown to improve the outcome better with low carbohydrate diet when compared to low fat diet. There is something called as HOMA-IR that improves dramatically with carbohydrate restriction for treatment of metabolic syndrome. More studies showing that in a eucaloric high carbohydrate intake versus low carb high fat diets, metabolic syndrome is improving. The multiple meta-analysis that were done conclude that ketogenic diet is more effective in weight control and metabolic parameter control, and also HOMA-IR that improves. But also sometimes they say, oh, fasting blood sugar goes up, but we should understand that fasting blood sugar that occurs in the morning with a glucose surge could be a counter-regulatory hormone effect rather than being a critique of ketogenic diet's effectiveness. So there's other studies, including a 2-year study that showed that in the carbohydrate arm, there is reduction of hemoglobin A1C better, and there is less variability of glucose. And there are 62 clinical trials that are available for anybody who doubting Thomases that are out there for this lifestyle to go and review on this website and Public Health Collaborative, which is freely available online. So my interest in this more peaked after I started looking into this into my own lifestyle, but also at the end of 2019, I came across this study that showed that gamma delta T cells in the lung improved in the mice when they were subjected to ketogenic diet after they had been exposed to influenza. And that was a head scratcher, and I was saving up this study for discussing further down the road. But it so happened that COVID happened, and then I wrote an opinion piece on this to show that T cells response is very much central to how we need to understand our own process regarding T cells and COVID. So that's a separate discussion. Coming back to the topic, we have to understand that ketogenic diets have a strong evidence for diabetes with mechanisms showing reduction in insulin levels cardiovascular mechanisms showing reduction in HMG-CoA reductase activity, and also insulin levels that are reduced, and increased LDL particles. Here, the LDL particles that are normally taught is not the kind of LDL particle that come here, and these are large fluffy LDL particles. And there is weight reduction, obviously. Most people use this for doing ketogenic diet, but this ketogenic diet has myriad other outcomes that need to be studied. But here with ketogenic diet, the mechanisms are improved appetite, reduction in lipogenesis and increased lipolysis, and increased metabolic cost of gluconeogenesis that causes more thermic effect. Obviously, epilepsy has been proven. But more effectively, then there's studies that need to be done for neurological diseases, that is, that possibly are they showing emerging evidence for this. And cancer is something that is of very interest because of a new theory wherein even cancer is being considered with something called as press pulse theory, where people are being kept in and put into ketogenic state, where they are in nutritional ketosis, and they are being put into hyperbaric conditions. I would say rather there are studies being done for that, but there are mice studies proven from University of South Florida that show that in cancer patients also getting hyperbaric therapy, it is positively shown some improvement. In PCOS, it is showing some effective reduction in insulin levels, obviously insulin-like growth factor reduction that improves outcomes in PCOS. So coming to the fatty liver, which is the real pandemic that nobody talks about, wherein ketogenic diet has shown significant improvement with reduced macrophage activity. There is a macrophage 2 activity that is very much need to understand that. But there is histone acetylation, there is improved satiety, there is decreased fat reduction, there is decreased oxidative stress, decreased inflammation, decreased fibrolysis, and fatty acid and fatty liver improvement. Obvious microbiome also helps. But we have to understand that with COVID and also with other respiratory viral infection like influenza, this is an amazing article that shows that multiple cellular mechanisms whereby ketones influence in the SARS, possibly SARS, but also influenza, wherein there is antioxidant and anti-inflammatory and mechanisms that really show that there is improved neuroprotection, and also there is cardiac function improvement, there is gut microbiome changes, and also there is improved glycemic control and anti-inflammatory signaling that improves. And basically, what is more important is understanding that there is glycolysis, there is molecular mechanisms of ketone bodies that are relevant to the viral processes, wherein there is decreased NLRP3 activity because of beta hydroxybutyric, and obviously the glycolytic activity, the reactive oxygen species is reduced, and also there is inhibition of HDAC protein, and that whole process of multiple understanding of this etiology of ketone mechanism of ketone bodies understanding is very much needed. So contraindications to ketogenic diet are these deficiency of carnitine palmitoyl transferase and fatty acid beta oxidation deficits, and also long chain metabolism deficits, porphyria, pyruvate carboxylate deficiency, and potential contraindications of cancer, but more studies have to be done. Diabetes that need to be closely monitored, and because of medication adjustment, and familiar hyperlipidemia, kidney failure issues that need to be studied, and people who have bariatric surgery that can go hypoglycemic, and pregnancy and breastfeeding is being closely looked at. So potential non-scale benefits, like I said, appetite suppression, satiety, improved gut health, and improvement in metabolic blood work, reduction in need for medications. Also, there is side effects including urination, because the less insulin, the fluid edema retention will reduce, so the people will urinate a lot. So hydration is very much necessary. Keto fluid can be prevented by adequate electrolyte replacement, and fatigue can be prevented by adequate electrolyte replacement. Anxiety, keto breath, and diarrhea. People are possibly not eating right when they have that, but also people can have a problem if they drink alcohol. The alcohol tolerance does go down when people drink. People are in a state of nutritional ketosis. And University of Indiana study that has done that is showing that this lifestyle is overall positive. It is showing that there is a reduction of costs, there is improvement of hemoglobin A1C. It is sustainable process, and this trial is going to 3 years, and now they are looking at putting into 5 years of this study. So what is international guidelines regarding carbohydrate restriction? Even in 2011, Diabetes UK said may be considered. In 2015, it was recommended. But slowly over time, Diabetes Australia agreed about it. But then in 2019, American Diabetes Association showed that is something that it is worthwhile looking at. So, and Diabetes Canada came up with a position paper in 2020 April regarding low carbohydrate diet and diabetes. And here you have the ADA changing its tune slowly, saying that low carb and very low carb dietary pattern is a viable option. And obviously, it's asking to choose whole foods, minimize added sugars and refined grains. When they say that, you have to be careful, because we have to understand that grains are still sugars, and human behavior can be very addictive. We'll talk about that. So the recommendation now for therapeutic consideration for therapeutic carbohydrate restriction is understanding that we have to have diabetic medications that have to be tapered. There is a recommendation article, and also we have to understand how to responsibly reduce the medications, and also understand that there will be changes with fluids, electrolytes, increased risk of kidney stones initially because of not hydrating well, and also over-the-counter recommendations need to be closely monitored. So we have to understand that there is 6 functional pathways leading to aging and death. Of those, it's glycation, mitochondrial dysfunction, oxidative stress, insulin, leptin resistance, inflammation, and metabolic instability. All the above problems are not druggable. They are only foodable. So we need to help our patients choose the right food, because food is an epigenetic factor. It helps with epigenetic expression, immunity, inflammation, increasing or changing muscle mass. Health through food strategies have to be applied. It has to be beyond medicine as food. It has to be healthy cooking, social foundation, social connection, shift from health to well-being, a shift from medication to mindfulness, and also incorporating self-sustaining behavioral process changes through high-touch solutions. Barriers including inadequate training, lack of support, and belief systems. We have to start somewhere, and that somewhere is through a lot of education like these activities. And dietitians have to open up and understand that there is other options. Healthcare societies have to understand that we cannot drown innovation. And we have to understand that even William Banting in 1863 wrote this book, and the Corpulence book, that was the first diet book. And we have to understand that these changes need an individualized protocol wherein nutritional ketosis can be applied, understanding the ketones, weight, energy, understanding the blood sugar, blood craving, biomarkers, developing an individualized clinical guidance that is adapted to that one person, understanding the history of the patient, family history, motivations, life changes, dietary restrictions and patterns. All these need to be put into a continuous remote care via telemedicine and interdisciplinary team, understanding the medication delivery process, coming up with a nutritional ketosis that could be a personalized solution. And optimized therapeutic nutrition needs to be delivered using data tracking and telehealth. And I have done that, and people get happy. And this was one of my patients posting on Instagram regarding that simple technique of losing 22 pounds in 2 months. This is another patient apart from the first patient I showed in the case. So what is key takeaways? Remission of chronic disease is possible with food first approach. Dietary lifestyles have to come before medication lifestyle. Nutritionally educating the physician is an important role, and whole foods diets are the starting point in chronic disease. We have to pick different approaches and help our patients through their life journey. Non-communicable diseases are the real pandemics, and these are the chronic diseases that are slow moving pandemics that influence outcomes of conditions like other infectious disease, including COVID. We have to understand that this does not happen just by nutritional path. There is a huge addiction path that we have to help our patients master for themselves. And that's where the personalized lifestyle comes in. The future is of n equal to 1 solution. Multiple parameters can be looked at, surrogate markers can be looked at, and that needs a whole program that needs to be developed. And this is one of the groups that I started earlier in January, a group of doctors in India, almost 250 of them. And I just had one of my friends do a simple survey, Survey Monkey, found that only 24 people responded. But out of that, we found that 33% of them are currently on low carb and 12% on ketogenic. But amazingly, what I found is Indian doctors mostly, showing that 38% of them are vegetarian and 4% vegan. And people who want to do low carb diet, amazingly, people doing is 33%, and people who want to do low carb diet is 61%. So obviously, vegetarian low carb is what I have to focus, and I have to learn and teach them how to teach their patients also. So this is an amazing challenge, amazing journey. So we have to understand that research is what everybody else has seen. We have to think what nobody else has thought. Everyone, including the patients, have a doctor in him or her. And the natural healing force within each one of us needs to guide us to getting well. Our food is our medicine is our food. And all medicine, I say, is personal. And every patient is a puzzle. And we are to move away from mass medicine mindset to enough on medicine. We can come up with proper nutrition or supplementation for healing and recovery. Or better yet, can we prevent metabolic injury? Let's think about it. Thank you very much. Here are a few other references for this talk, and please feel free to connect with us.